Thank you, Joseph. I have to go very quickly, but nevertheless, I'm proud to present the ESMO ESDO. It's important to mention also the European Society of Digestive Oncology. With a group we sat together, and we have a very strict process of going through the guidelines. They are available on the ESMO website, so please read them afterwards today. I have to congratulate the audience because I went through all the answers on the questions, and the majority is following the guidelines, either intuitively or because of the fact that you have read all the papers of Dr. Lovett and followed the ASLD, EASL guidelines, but I'm happy with the responses of the audience, so I can go very quickly through everything. I picked some issues from the guidelines, but you all agree that we have to survey patients with cirrhosis using abdominal ultrasound every 6 months. But we know when we do surveillance, we will find lesions that are smaller, but nevertheless, there may be some patients who are really advanced at the time of surveillance. And when we survey patients, they may do better, but you need some randomized evidence to make really your government and your healthcare officials aware of the need of and the benefit of surveillance, and therefore you need a randomized trial, and this has been done in China. You can criticize the Chinese for many things, but and especially this trial also, the randomization process, how they really designed the trial, but nevertheless they could show a survival benefit in patients who were surveyed for HCC in a hepatitis B population. But there is a big problem that in many academic centers, and this is a US study, but this will be the same also in Europe, that when you look to problems with screen failure, either patients do not get the examinations, or they are not called when there is a positive finding for follow-up, or there is detection failure, well, there is some variation among different centers, and we are not doing probably very well in doing this surveillance in patients with cirrhosis. So this is a main challenge, especially also in the Western world. The diagnosis, well, we had some questions about that. Is an MRI sufficient? When you go through the guidelines, indeed, when you have a typical contrast uptake and washout in the venous phase, you may be sure in a cirrhotic patient that he has indeed HCC. But the problem is you have other rules, and the rules of transplantation are very dominant. And in the Eurotransplant region, it's not enough when you have a unique small lesion. You need to have another exam. You need to have perhaps a high alpha-fetoprotein, because the Eurotransplant region is using the criteria of 10 years ago. So we need also a little bit of an update. And why are they so strict? Well, there is anxiety that we would transplant patients with pseudo-lesions, with vascular lesions that are not HCC. But still, there is some room for improvement. So you can follow the ESMO guidelines, but it is your transplant group that really will decide whether they need additional exams. The staging, we have the Barcelona group leader here, and indeed, this is the most important staging system, and it's a very good system. It's endorsed by all the societies in the world, especially because there are also some link to the treatment of the patient. There have been some small changes in recent years. Most important, a very small lesion in a cirrhotic patient that is not a candidate for transplant. You can treat this with RFA and not because of resection. This is in the very early stage. But for the rest, this system has been rather stable in recent years. And so we copied this in the ESMO. We are a bit more flexible in the early stages in the ESMO guidelines, and this is the matter of discussion among the group, but nevertheless, there is some problem in the guidelines. And this was also illustrated in the second case, because he presented a case, colleague Weber, of someone who, in my opinion, has an advanced HCC from the beginning. This patient presented with abdominal pain, a tumor-related syndrome of a huge lesion in the right liver lobe. And when we look to the performance status or the tumor-induced symptoms, it's very important to pay attention to that. You can only talk about an intermediate HCC when you have no tumor-related symptoms, according to several studies. But in several article manuscripts, when they discuss intermediate HCC, you see you can have also a PS, a performance status, varying between 0 and 2. But this is not correct, because if you have tumor-related symptoms, you are in fact in an advanced stage HCC. You may say, yeah, can't we do anything for our patient? Well, I come to this later on in my talk. Even in study protocols, when they talk about, this is design of an interesting study protocol in Holland, intermediate stage HCC with an ECOG status 0 to 1, but as long as it is not related to the tumor, for me it's fine, but if there are really tumor-related symptoms, it may be problematic to have this as such written in a protocol. And just remind you, you know all the ECOG, but we always talk about ECOG 0 and 1. You all are now ECOG 1 probably. I haven't seen you walking around, but when you have ECOG 2, you are really already very, very sick. The most important thing from staging to therapy assignment. The early HCC, it's curative intent. Advanced HCC, palliative intent, sorafenib. And then the problem with the intermediate HCC, and the point I want to make is, this is perhaps a better name to call it an indeterminate stage. It may depend a little bit on the response of a certain treatment, whether the patient will go to a possible therapy with downstaging for a more curative intent, and on the other hand, these patients may advance to a palliative situation. And from the beginning, it's not always clear. So I make the proposal now to call this stage in some patients indeterminate in comparison with pancreatic cancer, where you have the borderline resectable tumor. Well, it may be the same in HCC, but of course, we should further discuss this point. The problem with guidelines versus clinical practice. Just one paper that shows you that in patients who were considered to have BCLC stage B, 100 patients in an academic center, that you have the entire variability of all the possible treatments in first line. So even in academic centers, these guidelines are not always followed. So we have to be aware of this reality, but nevertheless, we have to stick very closely to the staging of our patients. So, last thing, our colleague Weber showed you an interesting survival. The survival of a patient is dependent on several factors. The natural history of the disease, liver function, comorbidities, and therapy. When you have to teach to your colleagues or your doctors in training one thing about HCC, please show this slide. This shows the natural history of HCC without doing anything. Without doing anything. And you can have a 5-year survival without doing anything. It all depends on some additional prognostic factors which are essential to stratify in studies. So please, you can have an excellent survival without doing anything. Even you can improve the survival by not doing a toxic therapy. So the take-home messages from the cases, importance of surveillance for HCC, but there are even screen failures in academic centers. Correct staging of patients is important. Mixing up BCLC, B and C is something that really happens, and it's important for therapy assignment to be strict, and overall survival assessment of this from a single case is difficult and a challenge.